Artificial Intelligence Dr. www.abcpharma.net/English. User question: how do different treatment modalities, such as laser iridotomy, lens extraction, and medications, impact the long-term outcomes of patients with narrow angles and angle closure glaucoma, and what are the optimal treatment strategies for different stages of the disease? Claude AI answer: this is an excellent and comprehensive question that addresses a critical aspect of managing narrow angles and angle closure glaucoma, ACG. The choice of treatment modality can significantly impact long-term outcomes, and optimal strategies may vary depending on the stage of the disease. Let's break this down. Treatment modalities and their long-term impacts. 1. Laser peripheral iridotomy, LPI. Long-term outcomes. Effective in preventing acute angle closure attacks in many patients. May slow progression of angle closure process. Does not always prevent chronic angle closure glaucoma development. Impacts. Reduces risk of acute attacks by 47,100% in various studies. May not significantly affect intraocular pressure, IOP, in chronic cases. Can cause visual symptoms, glare, diplopia, in some patients. 2. Lens extraction, clear lens extraction or cataract surgery. Long-term outcomes. Highly effective in opening the angle and reducing IOP. May eliminate need for glaucoma medications in some patients. Provides additional visual benefits if cataract is present. Impacts. EAGLE study showed superior efficacy compared to LPI in primary angle closure glaucoma. Reduces IOP by average of 4-8 mm of mercury long-term. Lowers risk of acute and chronic angle closure progression. 3. Medications. Long-term outcomes. Can effectively control IOP in many patients. May delay need for more invasive interventions. Efficacy can diminish over time. Impacts. Prostaglandin analogues can reduce IOP by 25–35%. Beta blockers, alpha agonists, and carbonic anhydrase inhibitors also effective. Side effects and adherence issues can affect long-term success. 4. Argon laser peripheral iridoplasty, ALPI. Long-term outcomes. Can be effective in widening the angle in plateau iris configuration. May be used as an adjunct to LPI. Impacts. Studies show sustained angle widening in 72% of eyes at 6 years. Less commonly used as primary treatment. 5. Minimally invasive glaucoma surgery, MIGS. Long-term outcomes. Emerging data on long-term efficacy in angle closure glaucoma. May provide additional IOP lowering when combined with cataract surgery. Impacts. Procedures like Hydrus microstent show promising results in angle closure patients. Long-term data still accumulating. Optimal treatment strategies for different stages. 1. Primary angle closure suspect, PACS. First line, laser peripheral iridotomy. Monitor for progression. Consider prophylactic clear lens extraction in high-risk cases. 2. Primary angle closure, PAC. Laser peripheral iridotomy. IOP lowering medications if needed. Consider early lens extraction, especially if cataract present. 3. Primary angle closure glaucoma, PACG. Lens extraction, if phakic, often preferred as initial treatment. Combined with IOP lowering medications. LPI if lens extraction not feasible. Consider filtering surgery for advanced cases. 4. Acute angle closure. Immediate IOP lowering with medications, oral IV acetazolamide, topical agents. LPI once cornea clears. Consider early lens extraction after acute attack resolved. 5. Chronic angle closure glaucoma. Lens extraction often beneficial. Ongoing medical management. Filtering surgery for uncontrolled cases. Factors influencing treatment choice. 1. Angle configuration. Pupillary block versus non-pupillary block mechanisms. 2. Lens status. Presence of cataract, lens thickness. 3. Age of patient. Younger patients may benefit more from early lens extraction. 4. Extent of PAR, peripheral anterior synechiae. Extensive PAR may limit efficacy of LPI alone. 5. IOP level and control. Higher IOP may necessitate more aggressive intervention. 6. Visual field and optic nerve damage. More advanced damage may require more definitive IOP lowering. 7. Patient preferences and compliance. Surgical versus medical management considerations. 8. Ethnicity. Higher risk of aggressive disease in certain populations, e.g., East Asian. Future directions and challenges. 1. Personalized medicine. Developing predictive models for individual treatment response. 2. Combination therapies. Optimizing combinations of different modalities, e.g., MIGS plus lens extraction. 3. Long-term comparative studies. Need for extended follow-up comparing different treatment strategies. 4. Novel therapies. Investigating treatments targeting specific angle closure mechanisms. 5. Prevention strategies. Identifying and treating high-risk individuals before glaucomatous damage occurs. In conclusion, the management of narrow angles and angle closure glaucoma requires a nuanced approach, tailoring treatment to the stage of disease and individual patient factors. While laser iridotomy remains a cornerstone for early intervention, lens extraction has emerged as a powerful tool, especially in more advanced cases. The optimal strategy often involves a combination of approaches, carefully selected based on the patient's specific presentation and risk factors.